Everyone, and a warm welcome to Oncology Conclave 2024. Today we have an exciting lineup of sessions focused on GI, GU, and gynecological cancers. We are honored to have you with all of us, what promises to be an enriching and insightful event. So, to set the stage and formally commence the proceedings, I would like to now invite Dr. Rakesh Taran sir, who is consultant medical oncologist and director of Taran Oncocare Indore. Over to you, sir.
Very good evening. Extremely gladful to have all of you here on the Oncology Conclave 2024. Yesterday was a wonderful session by some of the prominent speakers pan India, and today 15th November we are again going to have few of the good topics in medical oncology and oncology per se. I would like to invite Dr. Taha Sedjiwala, who is the head MOC Indore. He is going to speak on transforming patients' outcome with newer innovative therapies in first line advanced metastatic HCC. So, Dr. Taha, please. Dr. Taha.
Sir, he's there. Dr. Tak, can you just unmute yourself and maybe if you can check your presentation? अभिमन्यु एक बार सर को पर्सनल फोन कर दो.
1 सेकंड का सर कर रहा हूँ. सर ताहा सर का थोड़ा ऑडियो का इशू चल रहा था, वो जस्ट लैपटॉप चेंज करके अभी ज्वाइन कर रहे हैं फिर से.
Sure, sure.
I would like to inform all whomsoever has joined that there is a small change in today's presentation. Dr. Amit Joshi will be there at around 8:35, and Dr. Shrikant Tiwari is going to take the lecture at around 8:20. Some schedule change because of uh, previous commitments. Abhimanyu? Abhimanyu bhai?
Yes sir.
Can you ask Dr. Sunit
मैं बोलता हूँ सर.
to join because if it takes some time?
Yeah, yeah. Rakesh, sir, just give us 5 minutes. We're just coordinating. Dr. Taha is just joining. I think he has some issue with the laptop. अभी 5 मिनट में शुरू हो जाएगा. We'll just wait. Sorry for this. Apologies for this inconvenience. Next 5 minutes, we're going to start the session.
Okay.
Hello.
Yeah, good evening, sir. Thank you so much for joining. So we are all
Very
set.
sorry, there's
Thank
some
you so
technical
much.
issue actually.
Yeah. So Samar, can you allow Dr. Taha to share his screen?
Yeah, sure.
Yeah.
It's okay. I can just continue the same. You can just share my presentation. You can go
Yeah.
ahead with that.
Okay. So you want us to present or
Yes,
okay.
yes, yes.
Okay.
Just
Okay.
continue.
So Samar, please go ahead. And Dr. Taha will say next slide, next slide. Please, sir.
Hi. So good morning, sorry, good evening, everyone. So first, I would like to thank Taran sir for giving me this opportunity and AstraZeneca for again letting me present this. So in the next 15 minutes, we'll be talking about transforming patient outcomes with innovative therapy in advanced unresectable hepatocellular carcinoma. I think all of us understand that hepatocellular carcinoma, when it is unresectable, it is difficult to treat. And I think till 10 years back, we didn't have much treatment options, but now we have a variety of treatment options. And one of the options we'll be discussing now in these next few slides. Next slide, please. So looking at the global incidence and mortality. So liver cancer is the seventh most common cancer and the fourth most frequent cause of cancer-related deaths globally. Next. Uh, in 45% of the cases, it is usually spread to either lymph nodes or metastasized to other organs. And what we've seen is that the survival drops drastically. So from localized, if you have around 31%, drops to around 2.4% when distant, and 10.6 when they are regional nodes. Next slide. Now talking about hepatocellular carcinoma in India, there is a slight difference. So in India, liver cancer is this 11th most common cancer type and 8th most common cause for cancer-related deaths. HCC being the second most common cancer death in men. Now, talking about incidents, around 38,000 cases and of deaths of around 36,000. So, as you can see, there's not much difference in the incident and the deaths. That just shows you how high the mortality is. Talking about the male-female ratio, it's around 4:1, with a median age of 40 to 70 years, and the frequency increases with age. Talking about incidence of HCC in cirrhosis in India is 1.6% per year. Next slide. Now, talking about what causes or what contributes to the HCC development. So, main thing is the inflammation and the immune dysregulation. That is one reason why immune checkpoint inhibitors have a very crucial role to play in the management of HCC. So, the three common etiological factors: viral, that's chronic infection causing apoptosis and cell death. Other is metabolic syndrome, that is NASH, non-alcoholic steatohepatosis, again causes cell death or cellular state. And the third is chronic alcohol abuse. So all these lead to inflammation by dysregulating the liver immune network, causes immune suppression, exhaustion, missing tumor surveillance and proliferation and pre-oncogenic transition. And all this leads to HCC by fibrosis changing to cirrhosis. So the multiple mechanism of immune escape and evasion, including overexpression of CTLA4 and PDL1, and there's inhibition of antigen presentation. Next slide. Now again, talking about the same things, there is factors, that is a viral, substance abuse, metabolic, and others. Everything ultimately leads to chronic inflammation, cirrhosis, and HCC. Next. What you have to understand is the metabolic causes, which are becoming basically the commonest risk factors for causing HCC, and we'll look into it again in few slides. Next slide. Yeah, so if you talk about the etiological fraction in patients in India, what we understand is the most common etiology of HCC was NAFLD, that is NASH, non-alcoholic fatty liver disease, followed by viral hepatitis B and C, which is unlike the rest of the world where the viral hepatitis is more common. And that is why the treatment issues need to be sorted, which have to be a little different for Indians. Next. Coming to the management of advanced unresectable hepatocellular carcinoma. This is a flowchart, a busy slide. But if you look at the right side, we are mainly talking about the advanced stage. That is portal invasion or the where there is extrahepatic spread. Now here it's mainly systemic treatment. And the options first line are Atizo, Bev or Durva, Tremelimumab. If not feasible, there are oral TKIs. The second line options being regorafenib, cabozantinib, ramucirumab. Third line is again cabozantinib. Next slide. So as you see the evolution of systemic treatments in HCC. So between 2007 2017, there was a 10-year gap between first TKI, sorafenib, then we had the second line, regorafenib came. And then from 2018 onwards, we have multiple options which are available. Lenvatinib, atezolizumab, and the recent most the approval that has come for tremelimumab and durvalumab. That's what we'll be discussing. Next slide. So how these individual drugs got approval? First one was sorafenib. That was the SHARP trial. So compared sorafenib versus placebo. The OS difference was around 10.7 versus 7.9. The other was the REFLECT trial, where lenvatinib was compared to sorafenib, and you had a difference of barely 2 months. So what we understood was the modest improvement in OS and considerable side effect associated with both treatment underscores the unmet need for better clinical outcome in the management of HCC. We need something better than just TKIs. Next slide. That's why the immune checkpoint inhibitors came into being, but we had to give it along with anti-VEGF. So IMBRAVE 150 was the first phase 3 trial which studied atezo plus bev versus sorafenib in first-line advanced unresectable HCC. Patient had to be locally advanced, unresectable, no prior systemic treatment. And again, Asia, excluding Japan, rest of the world, ECOG 0 to 1 with alpha fetoprotein, we had the stratification. Atezo bev versus sorafenib 2:1 ratio. The co-primary endpoints were OS and IRF assessed PFS, and we had other secondary endpoints. Next slide. So what we saw was nice separation of the curves with median OS of 19.2 versus 13.4 months with the hazard ratio of 0.66. That was the OS. Talking about the PFS, again 6.9 versus 4.3 months. So both were were significant values, and that is why it became the first line of treatment when it came to unoperable HCC. Next slide. But what we saw in the subgroup analysis was when there was the viral etiology, the treatment did very well. But what about the non-viral hepatocellular carcinomas? If you look at this forest plot, what you understand is it does not fare that well when it is about non-viral etiologies. And that is why we have to be a little careful while using this combination in such patients. Next slide. Another problem with this combination, as all of us do understand, is the side effect profile. It's not a very convenient option because most of the patients, what we see, have cirrhosis, they have variceal issues. And one of the common side effects has been bleed when we talk about bevacizumab. So we have to be careful. Apart from that, other side effects like hypertension, proteinuria are also a problem. Also loss of appetite and diarrhea. Next slide. So that is why we had to incorporate an option of dual checkpoint inhibitors so that the side effects of BEV would be taken care of. Next slide. What is the rationale for combining dual immune checkpoint inhibitors, anti-CTLA4 plus anti-PD-L1? The important thing is anti-CTLA4 acts in the lymphoid compartment to increase the number of T-reactive cells. And the anti-PD-L1, what it does is it prevents T-cell inhibition. And that is why you get an enhanced synergic tumor activity. Next. Again, the same thing. The combination of durva with tremelimumab, it increases the anti-tumor activity by reversing the T-cell exhaustion and allowing T-cell activation. Next slide. So ultimately what you're doing is increasing the T-cell effect on the cell. So they studied in various trials. What they understood was that durvalumab was basically your PD-L1 inhibitor. Apart, when you add a anti-CTLA4 with it, there's a synergistic effect which increases the efficacy. But what is important to understand was that whether a single priming dose of tremelimumab was sufficient. And this is what they had seen in various trials, like we see in melanoma also. Only initial boost of ipilimumab is sufficient to get a good response. And that is what they incorporated in this trial. Next slide. So this was the STRIDE regimen, where rather than using tremelimumab multiple doses along with durva, what they saw was a high dose of single shot of tremelimumab was sufficient. And that is what they used in the Himalayan study. Next slide. Yeah, so this is the phase 2 study which showed that monotherapy with tremelimumab was sufficient. You look at the median OS also, we got the best result with the stride regimen. So it gave the longest median OS in the study. Median OS with T300 plus D was more than 3.6 months longer than the other treatment. And also the safety profile was very good and there were no new safety signals. Next slide. Then you come to the Himalaya study, that is a phase 3 randomized open label multi-center study where tremelimumab plus durvalumab as first line treatment for unresectable hepatocellular carcinoma. Next slide. The inclusion criteria of patient more than 18, BCLC stage B or C, no prior treatment, child PUG A, that is important, and ECOG 0 to 1. It was 1:1 randomization where there are 4 arms. A was the stride regimen, what I just told you, a single shot of tremelimumab along with durva, which is continued 4 weekly. Next arm was only durvalumab, arm C was sorafenib, and arm D was durva plus tremelimumab for 4 doses. But this arm was discontinued further, and only 3 arms were studied. Primary endpoint being OS, was secondary endpoint being OS and responses, and further PFS. Next. Now, again, just to explain it better, one was durvalumab monotherapy. Arm B was durva plus tremelimumab for 4 doses. Arm C was durva and tremelimumab single priming dose. That is the stride regimen. The arm D was sorafenib. So in this, the second arm B was discontinued. Next slide. If you look at the demographics, fairly well balanced. Looking at the regions, Asians were a lot. That's 40%. That is good. And talking about the etiologies. So again, viral versus non-viral, around 50-60% were viral etiologies, non-viral 40%. That is again, which fairly balances how we are looking at the picture here. Next slide. Talking about subsequent second line therapies, most of the patients received target therapy following initial immunotherapy, but there are some patients who had received immunotherapy after the initial dual checkpoint inhibitors. Next slide. Coming to the results, so it demonstrated a statistically significant improvement in median OS versus sorafenib. Those who received the stride regimen had 22% lesser death risk compared to patients who had received sorafenib. And at the end of 3 years, you get a difference of around 10%, that is 30.7 versus 20.2%. So looking at the median duration of median OS, 16.4 versus 13.8 months. Hazard ratio is 0.78 with a significant p-value. Next slide. Now, coming to the forest plot, what you understand is the non-viral subset. That is what we discussed in the IMBRAVE study. So here, the important thing is even the non-viral etiology has done very well. And these are the patients which we can target using the stride regimen. Next slide. Talking about the responses, again, we see very good responses. Overall response of 79% versus 20. Looking at the median duration of response also, there is 22.34 versus 18.43 months. That is again quite significant for a patient with unresectable hepatocellular carcinoma. Next slide. Now this is again important, the side effect profile. What had been a concern with the combination of atezo-bev. What we understand here is that the side effects are lesser compared to sorafenib. When we talk about any TRAIs, talking about grade 4 also, the side effects were higher with sorafenib versus dual checkpoint inhibitors. But yeah, of course, the immune-related side effects were higher with this regimen. And next slide. Yeah, so again, the same slide in different form. You get the higher side effect in the form of rash, pruritus, and diarrhea. You can see the slide. Then the important thing, that is the hemorrhagic side effects that were very higher with the bevacizumab regimen. Here, what we see is that side effects, the patient with hemorrhagic, that is a very low, 7 versus 2%. Also, esophageal varicose hemorrhages were 0. That is again significant. Next slide. And look at the NCCN guidelines. What you understand is now it is very well recommended in category 1. Now, looking at atezo-bev versus tremelimumab and durvalumab, how to choose between the two? I think one is a side effect profile. Patient with varices and all, you will definitely prefer dual immune checkpoint inhibitors. Where has to be avoided. A relatively milder regimen, unless we have a cross trial, head-to-head comparison, we cannot compare both the regimens. But you can choose basis of one is your side effect profiles. Apart from that, the responses, they are longer duration of response what you're getting from the combination. Next slide. So coming to the conclusion, HCC is one of the topmost common cancers affecting Indians, and there is shift from viral to non-viral etiology. That is again a point which favors a dual checkpoint inhibitors. They've done very well with non-viral etiology compared to combination of atezo and bev. Immunotherapy combinations have shown better anti-tumor activity. Atezo-bev had been a new standard of care. The STRIDE regimen, that is single tremelimumab with durvalumab, improved OS versus sorafenib and unprecedented 3-year OS rate. It seems to benefit across all subgroups, including non-viral etiology, and is well tolerated with low rates of discontinuation. So, STRIDE and Durva monotherapy present a potential new treatment option for patients with unresectable hepatocellular carcinoma. Next slide. Yeah, thank you so much.
Thank you, Dr. Ta. It was always great to hear you.
Thank you, sir.
As always, again, very crisp presentation and very to the point things. The thing is, how have you? What is your experience personal with Durva in oncology at Kokilaben Dhirubhai Ambani Hospital, Indore? And he is going to take us through immunotherapy in colorectal cancer. Dr. S.P. Srivastava, please.
Good evening, sir, and thank you for your kind introduction. I'm not a director over there, sir. So,
come on, if you are alone, you are the director, you are the boss, and you are HOD. Everything you are is there.
sir, my slides are visible, sir. Hello.
Yes, sir.
Yes, sir, it is visible.
Oh, that's great, sir. So, first of all, thanks to Rakesh Taran, sir, for giving me the opportunity to discuss something which is a evolving thing in our clinical practice, that is the immunotherapy in colorectal cancer. In hope so in future time, we'll have a significant much data with many of the trials. But today I'll try to take you to the journey of that how and what are the approvals are there and where what are the indication or where in which setting you can use immunotherapy in colorectal cancer as of today. So it is no conflict of interest. So in outline, we'll discuss about the current approval and rationale, future based on current approvals and dark side of the CRC. So in introduction, as we know this, we can use immunotherapy in cases of colorectal malignancy based on the PD-L1, PD-1 positivity or MSI or pol mutant CRC. So this is the depiction. It is a common depiction we usually read in our that how the protein mutation happen, new antigen increase the immunogenicity, and then the immunotherapy works better in those kind of patients. So there is a new antigen diversity in cases of the colorectal cancer. Here we can see there are just some of the biomarkers like TMB, PD-L1, MSI, POL. These markers we usually take into consideration before thinking for immunotherapy. But as of today, only the MSI is a biomarker which is a predictive for immunotherapy in colorectal cancer. Rest of like TMB, tumor mutation burden. So sometime if it is very high, then it can predict the good response, but usually it is a remains low. And even if we discuss about the MSI, it is hardly positive in 15% of cases, MSI high, and rest of the 85% cases are usually MSS. So responses are there with the when the MSI is high and pol mutant are there. So this is the graphic abstract in MSI. If we see this microsatellite and instability, we know that there are 4 proteins are included: MS2, MSH6, MLH1, and TMS2. And based on this, we can see in this depiction that high TMB, it is usually in mismatch repair tumors, that is colon cancers. And there is a high number of new antigens and high TMB and new antigens both are supporting for the use of the immunotherapies. So if we go in the history of this, in 2014, first PD-1 and PD-L1 inhibitor, pembrolizumab, was approved in malignant melanoma cases, and that was approved in second-line setting in colorectal cancers in 2017 after 3 years. But after many years, it has got approved in the first line. There are daily approvals are there, but not a very robust data what we have today. And but for CRC, how much have we achieved and what are the issues? We'll try to look into the next slide. This. So it is the evolution of ICE immune checkpoint inhibitor in metastatic colorectal carcinoma. We see the way back 2010, the study started as a phase 1 on nivolumab, and they have taken 20 patients, which showed the response only in one patient, later identified as a MSI high. So MSI high patient in phase 1 study responded for nivolumab. Later on, keynote that for pembrolizumab came into a phase 2 study, where 11 DMMR colorectal carcinoma patient and 21 stable MMR patients were taken, proficient MMR. Later on, one study that is on again phase 2 keynote 164 came into the picture, where they have taken metastatic colorectal cancer patients who were previously treated, and DMMR MSI high cohort was there, more than 2 therapies were received, and 63 in cohort B where more than one therapy were received. In that study, median OS was 31.4 months in cohort A and not reached in the cohort B. So these patients were DMMR or MSI high patient who responded. So these study gave some positive thought to use of immunotherapy in these MSI high or DMMR patients of colorectal carcinomas. Similar kind of success was achieved in Checkmate 142, where nivolumab mono as well as nivolumab ipilimumab combinations were taken. In both the arms, patients who are DMMR or MSI high, they have responded, shows a better response, and even and the progression-free survival. So after these studies, Keynote 177 came, where pembrolizumab was being tried in MSI high patient as a first line in advanced colorectal cancer. So this study came into 2020. This is the study design. It is an open label phase 3 study where there two arms were there. Pembrolizumab 200 milligram 3 weekly as compared to the chemo plus bevacizumab or chemo plus cetuximab. They have used FOLFOX6 or FOLFIRI in combination with Bev or cetuximab. They have taken patients with treatment naive MSI high or DMMR stage 4 colorectal carcinoma with a good ECOG performance status patients. And the treatment of pembrolizumab continue till the 35 cycles or until the unacceptable toxicity was there with the because of the immune responses. An optional crossover was allowed for chemotherapy arm to the immunotherapy arm. They have looked for OS as PFS as a primary endpoint and overall response rate, PFS2, and quality of life and safety as secondary endpoint in this. So here we can see the PFS and PFS2 analysis. So here we can see in the PFS survival curves, after almost 4 to 5 months of duration, there was a confusion, but later on, this immunotherapy lead the way, and it's a quite clear-cut separation of the graphs. We can see at 12 months and even on 36 months, there was a good separation. In 12 months, almost 20% benefit was there in immunotherapy. And at 36 months, it is almost 4 times, 11 versus 42 months benefit in the immunotherapy arm. So with the median PFS was 16.5 versus 8.2 with handsome HR of 0.59. So almost double the PFS with a very good PFS percentage benefit was there in the immunotherapy in this. And in the PFS2, here we can see again the similar kind of graph, and at 36 months, after 3 years, there was almost 60 versus 39%, 60% benefit is there in the immuno arm as compared to 39 versus in the chemo arm. So with again, the HR value was 0.61, so almost 41% of reduction in the events. And again, when we see the analysis of keynote 10177, here again, we can see this The median OS is not reached till now in pembro arm as compared to the chemo. It is 36 months with the HR of 0.74. So we see that the 3 years there is almost 10% benefit in the immunotherapy arm as compared to the chemo or chemo plus web plus cetuximab arm. So this trial has shown a clear-cut advantage in PFS as well as in the OS. So which led to path, it became the first line. It got the approval of pembrolizumab as a first line in metastatic colorectal carcinoma with DMMR or MSI high conditions. So in this sequence, the second trial which has got approved, that is with the nivolumab plus ipilimumab versus chemotherapy as first line. First line treatment for MSI high or DMMR metastatic colorectal cancer, that is M8SH trial. So in this, they have taken histologically confirmed unresectable or metastatic colorectal carcinoma with MSI high or DMMR status with good performance status patient. Stratification was done that the prior line of treatment, no patients were received any treatment earlier. And it is a study of 3-arm study where randomization was done is 2:1 ratio, where they have taken in one arm Nivo 240 milligram 2 weekly for 6 doses, followed by 480 milligram 4 weekly. Second arm, they have taken Nivo 240 milligram plus EP 1 milligram per kg 3 weekly for 4 doses, followed by 480 milligram of Nivo 4 weekly. And in the third arm, investigator choice of chemotherapy were considered, like FOLFOX or FOLFIRI plus VAV or cetuximab. So in this study, they have looked for dual primary endpoint in patient with centrally confirmed MSI high or DMMR status. That is the PFS by BICR and Nivo EP versus chemo, or in the PFS by BICR in Nivo EP versus Nivo. So all 3 arms were compared together. So it is a crowdy slides, but I tried to show everything in the one slide. Here we can see the PFS in the first A, where we can clearly see the graphs are totally altogether widely separated in Nivo EP arm as compared to the chemo. So clear winner is the Nivo EP in PFS benefits. In first line centrally confirmed MSI high or DMMR patients with if we see second graph where it is in the BRAF and KRAS and NRAS wild type and mutant patients. So in wild type and both the mutant patient, again the Nivo EP shows a wonderful results comparatively. The graph is widely separated with what we try to see in our clinical practice as well as. So and in BRAF mutant, again, we can see there is a Nivo EP is a clear winner. BRAF, KRAS, NRAS unknown. Again, here it is a clear winner. So mutation status does not change the responses or results. Liver metastasis, yes or no, in both the scenarios, Nivo EP again shows up better responses as compared to the chemotherapy. All the age group like less than 50 year, more than 70 year, less than 70 year, all 3 age groups are also showed a better response. So here we can see in this study that Nivo EP showed very good responses in all conditions, whether mutant, BRAF, KRAS, NRAS mutant, wild type or unknown, metastatic disease with the liver disease, where because we consider liver metastasis very bad prognostic conditions, all age groups. So in this Checkmate 8HW, they have concluded that Nivo EP demonstrated superior PFS versus chemo as first-line treatment in patients with centrally confirmed MSI high or DMMR metastatic colorectal cancers with HR value of 0.21. It is quite handsome, almost 79% reduction in the event in Nivo EP arm as compared to the chemo. And it was a PFS benefit across all the key subgroups. What they have checked in that MSI high and DMMR status is critical for appropriate treatment selection for metastatic colorectal carcinoma. No PFS benefit was observed with Nivo EP versus chemo in patients locally misdiagnosed MSI high or DMMR colorectal carcinomas. So these were the conclusions of this study. So these were the two studies which is looked into as a first line therapy in the cancer. Now they have looked looked at the neoadjuvant immune role of immunotherapy in locally advanced mismatch repair deficient colorectal cancer. That was a niche two study that is recently published in NAGM June 24th only, where they have taken 115 patients with DMMR colon cancers. 32 were enrolled in niche cohort. So niche cohort was initially taken, but later on this the protocol change and amendment was done. So it considered as a niche 2, where they have classified the patient on the basis of radiological assessment as CT3 or higher node positive and stage as per the AJCC. So here they have looked at the major pathological responses among patients and efficacy analysis. So what they have defined as or observed that less than 50% residual viable tumor were there in almost in 98%, but out of them less than 10% residual in 95% of out of them, zero residual in 68% of patients, and 11 to 49% were there in the 4%. So major pathological response was found in 95% patients, almost out of 109, it is 105 patients, quite significant number. And more than 50% of residual viable tumor indicate lack of pathological response. That was only in one patient, that is 1%, and unable to evaluate it. So we can see that there is a major pathological complete response for there in this study. It is the waterfall plot where we can see the major pathological response is quite significant, partial response is better than major pathological response, and this is quite significant in this all lymph node positive and negative, both the conditions. So they have concluded that in patient with locally advanced DMMR colon cancer, neoadjuvant nivolumab plus ipilimumab had an acceptable safety profile and led to pathological response in high proportion of patients. So that is for the neoadjuvant conditions. Later on, one more study we discussed, that is again phase 2 study where they have used modified FOLFOX plus bevacizumab and with or without nivolumab for the first line treatment of metastatic colorectal cancer. That is checkmate 928 randomized study. There, the key is that is a phase 2/3 study where they have taken histologically confirmed metastatic colorectal cancers, not amenable to curable resection, and no prior chemotherapy for MCRC. No prior treatment with checkpoint inhibitor, and good performance status was taken. Stratification factor, this tumor sided net left, right was taken in this prior oxaliplatin based chemotherapy, yes or no was there. So out of 195 patients, 2:1 ratio, they have randomized to Nivo plus standard of choice, that is mFOLFOX plus bevacizumab, and only the standard of choice mFOLFOX plus bevacizumab 2 weekly. So primary endpoint was PFS in this study. So data cutoff was in February 2021. In results, we can see the progression-free survival. The HR value is 0.81, not a very promising data in this study when it is combining with the target therapy, that is bevacizumab. And in the OS, there is still it is a HR is 1.03. Again, it is a no overall survival benefit when we are adding Nivo plus chemo plus bevacizumab. So it was a failed study, but it has given a thought, food for the thought that it might change or some eligibility criteria or some different profile protocols can came in, and the combination can help in future. So what are the challenges we have in colorectal carcinoma? There's a limited biomarkers are there. Only MSI, which is a straight away clear cut gives us a direction whether the immunotherapy will work or not. PDL1 and TMB not robust and has variation from study to study. And is immune checkpoint the only option as of today? As we have seen, the last study was the negative, but change in the future. So in conclusion, currently, if affording for immune checkpoint inhibitor, test MSI and POL, because if both are mutant, both are positive, then immunotherapy will work, and which gives us the guidance for the response rate. Offer immune checkpoint inhibitor upfront for DMMR metastatic colorectal cancers. Nivo EP may be better if toxicity not a major concern, because in our clinical practice, when we are using EP with Nivo, sometimes we may face the toxicity. Responses in neoadjuvant chemotherapy are inspiring, but for the phase 3 are awaited. Neoadjuvant chemotherapy with ICI rectal cancers, reevaluate patient every 2 months. Watch for pseudo progression. MSS needs more studies, because during this presentation making, I was reading some studies are there which are considering MSS also, and they are looking for the responses in MSS patients also. So future will tell us about the further role of immunotherapy in cases of metastatic colorectal cancer. But as of today, pembrolizumab, Nivo EP, both are got approved, and neoadjuvant setting also, that Nivo EP shows a better response rate. So this was from my side. Thank you so much for giving me the opportunity and being a kind listener.
Thank you, Dr. SP. And as you had rightly said, MSS studies which are in pipeline are going to play a major role, because for cold tumors you need something, because 95% of the time it's MSS patient, and you have some other ideas which can be coming.
Sir, I have read many of the article for this presentation. There are many things which are coming into the colorectal cancer, like CAR T cell therapy. They are going for the cellular therapies, and one more newer aspect that is based on one marker, which is still not in the practice. So in future, I think so, CAR T can be a major role in metastatic colorectal carcinomas. And I think so, these were the some studies which are practice changing for us also, although I have not tried immuno in colorectal carcinoma as of today, but I think so, I may try it if got the opportunity.
I had tried for a patient who was MSI high, and as we were discussing in the previous session, I had started with low dose,
Yes,
and it's almost more than a year. The patient is doing wonderfully well. So it works, and some of the patient it beautifully works. Thank you, Dr. SP.
thank you.
And may I now invite Dr. Kaushal Patel. He is a senior medical oncologist, Elite Hemat Onco Care Center, Surat. Dr. Kaushal is having very wide experience of clinical trials, and he's, I think, a pioneer in clinical trials running at Surat. And he's going to speak on management of metastatic urothelial cancer. Dr. Kaushal, please.
Yeah, thanks, Dr. Taran, for inviting me and giving me the opportunity to speak on your conference. I'm happy to share with some of the updates regarding the metastatic urothelial malignancy, particularly in view of the first-line treatments, and precisely we are focusing over the newer aspect of the treatments rather than discussing with the chemotherapy. If we see, then there is a higher burden of the bladder cancer in India, and it's a ninth highest incidence of the bladder cancer in the world. And if we see in India, then it's a 13th leading cause of the death in India amongst all cancer. If we see in India, then approximately 20% of the patients, they are having the metastatic disease at the time of the presentation. And these populations need treatments in view of the systemic aspect that need chemotherapy, IO, or something else. If we see the patients with the locally advanced and metastatic bladder malignancy, particularly the patients who are not into the local treatments, they are having a very poor prognosis. And 5-year overall survival of this particular population, they are less than 8%. And metastatic relapse after cystectomy is also common, and 70 to 90% of the patients relapse with the distal metastasis. If we see the evaluation of the eligibility criteria, then patients with the bladder cancer they are mostly depends upon the platinum eligibility criteria, particularly the cisplatin eligibility. And we have two criteria by which we can decide the cisplatin eligible and ineligibility. One is Glasgow criteria 2011, and another one is the Gupta's criteria 2019. And mostly this depends upon patient performance status, create clearance, peripheral neuropathy, and heart issues. In Gupta's criteria, the hearing loss is not in criteria to define as a platinum eligibility and ineligibility, but it includes the performance status and creatinine clearance combined. If we see the urothelial malignancy, then it's a chemosensitive tumors, particularly the platinum-based chemotherapy, and it quickly responds with the treatments and having good results. In randomized trial, approximately 65 to 80% of the patients with the locally advanced or metastatic urothelial cancer achieve the disease control with the first-line platinum-based combination chemotherapy. And maximum duration of the first-line platinum-based chemotherapy in advanced bladder malignancy is less than or equal to 6 cycles. We are not going beyond the 6 cycles to avoid the cumulative toxicity of the platinum, and there is no any added advantage of the continuation of the chemotherapy beyond 6 cycles. So since 1980, we have evaluation as a cisplatin as a most active chemotherapeutic agents in metastatic urothelial malignancy. Later on in 1992, the combinations with the platinum has came into the picture as a treatment's effective part. Since 1992 to 2017, there is no any updates into the management of the bladder malignancy during this 25 years of the time period. Later on, we have single agent pembrolizumab in cisplatin or platinum ineligibility patients, then came into the avelumab as a maintenance therapy after the induction of the platinum-based chemotherapy. Later on in 2023-24, we have Checkmate 901, which shows that the combination of the gemcitabine plus cisplatin plus nivolumab followed by the nivolumab maintenance therapy. And recently, we have EV plus pembrolizumab as a first-line category 1 recommendation will did best among all available options of the treatments. So if we see the switch maintenance therapy, the patient has responded with the first-line chemotherapy, and we will switch the patients to the IO maintenance therapy until the disease progression or unacceptable toxicity. And then later on, when the progression of the disease happen, we will initiate the second-line treatment option. The avelumab is the immune therapy drugs, which is most effective in the patients with the reduced tumor burden and high mutational burden like urothelial malignancy after the response with the chemotherapeutic, particularly the chemotherapy which contain the cisplatin-based combination chemotherapy. And this is the a systemic therapy according to the 2024 latest update. Pembrolizumab plus EV is the category 1 preferred regimes for the metastatic urothelial malignancy. Later on, the gemcitabine plus cisplatin or MVAC plus cisplatin, sorry, MVAC, and when the patient got the response, we will follow with the avelumab maintenance therapy. And recently, the nivolumab plus gem plus cis followed by the nivolumab maintenance therapy has came into the pictures with good result in Checkmate 901 study. If we see the Javelin Bladder 100, it's a phase 3 randomized trial and unresectable metastatic disease. The patient who has been treated with the 4 to 6 cycles of the cisplatin or carboplatin plus gemcitabine, and the patient who has responded in form of the complete response, partial response, and stable response has been divided in two parts: the avelumab plus base support care followed versus base support care. And the primary endpoint of the study is the overall survival rate. And there are many secondary endpoints, and preferably the progression-free survival rate and safety profile and tolerability. If we see the primary endpoint of the study, that's a median overall survival rate. So we can say that the near about 30 months of the median overall survival benefit has been documented with the avelumab maintenance therapy after the first-line chemotherapy. And if we see approximately 9.2 months of the absolute difference has been documented in median overall survival with 23% absolute risk reduction into the death as well as progression of the disease. If we see the maintenance avelumab has changed the first-line treatments with the more than double 2-year survival rate. We can say that more than 50% of the populations with the avelumab arm, they are survived beyond the 2 years. And 30 month is the median overall survival has been documented with the avelumab according to the latest update in 2022. If we see the real world overall survival data like Patriot 2 study and Ready study, it will also shows that there is a more than 30 months of the overall survival has been documented with the avelumab first line maintenance therapy after the response with the platinum-based combination chemotherapy. If we see the ASCO 2024 update in subgroup analysis, then all subgroup of the patients with the low tumor burden as well as high tumor burden shows the prolonged overall survival rate with the avelumab plus base support care. And if you see the patient who are having visceral metastasis, bony metastasis, and lymph node metastasis, they are all patients, they are getting advantage with the avelumab maintenance therapy compared to the base support care. If we see the progression-free survival rate, then it is also better into the patients who has been treated with the avelumab compared to the base support care. And it is almost more than double into the patient who has been treated with the avelumab rather than the base support care. Irrespective of the number of the cycle, the overall survival rate has been maintained, whether it's a 4 cycle or 6 cycles. The avelumab is continuing showing the advantage with the maintenance therapy compared to the base support care. And if we see the OS benefit with maintenance, avelumab is seen in first line chemotherapy, regardless of the chemotherapy regimes, whether it's a carboplatin plus gemcitabine or cisplatin plus gemcitabine. No doubt there is a little bit better advantage with the cisplatin-based combination chemotherapy compared to the carboplatin, but the advantage or differentiation of the curve has been maintained in two groups of the population. The aggressiveness of the metastatic urothelial carcinoma is reflected on the daily practice data, and sooner the better to start on avelumab therapy. So a median PFS is definitely better into the patient who has been treated with the avelumab plus base support care versus base support care. And the patient who received the first line treatments, approximately 70% of the patient, but the patient who able to receive the second line treatment option is approximately 30%. So it shows that the aggressiveness of the tumor, and it is better to start the treatments as early as possible with the avelumab maintenance therapy when the patient got the response. Whatever the response with the first line combination chemotherapy, whether it's a complete response, partial response, or the stable disease, avelumab has continued to show its advantage as a maintenance therapy in form of the overall survival rate compared to the base support care. The PFS of the 26.7 month in patients who are exposed to the avelumab maintenance therapy for the more than 12 months, and in this particular subset, still the median overall survival rate is not reached. So we can say that the patient who responds the avelumab more than 12 months, they are getting the better and better advantage with these particular drugs rather than the patient who are having short duration of the response. The efficacy of the avelumab first-line maintenance therapy has been confirmed in real world heterogeneous population also, with data more than 1,200 populations, which include the JB100, Avalanche, and Ready study. And it shows that there is a significant advantage of the PFS as well as OS has been documented compared to the base support care. And it consisted with the result which has been documented by the Javelin Bladder 100 clinical study. Unprecedented 40.8 month of the overall survival with rate has been documented with the real world study Avalanche. In this particular study, the first line platinum-based combination chemotherapy, and the patient who responded has been put on the maintenance therapy, and later on the patient progression of the disease, we continue with the second line EV according to the ASCO GU 2024, and it shows that there is a more than 40 months of the overall survival in such type of the malignancy. And this is a summary of the different studies and different molecules which has been used in first line treatments with or without maintenance therapy, except EV plus pembrolizumab in this particular subset of the populations. So here we can say that the combination of the chemotherapy followed by the avelumab maintenance therapy, and when the progression of the disease, we can go ahead with the second line EV, which shows the maximum duration of the response as well as the overall survival rate compared to the other available options of the treatments, whether it's a Javelin Bladder 100 without second line treatments, Checkmate 901 with nivolumab, or a single agent pembrolizumab or atezolizumab when the patient is ineligible for the platinum-based combination chemotherapy. When the progression of the disease over the IO, we have very limited options of the treatments, but the base treatment should be the first treatments in malignancy. When the patient progress over the IO first line, we have options of the available treatments with EV. If the patient is FGFR receptor positive, then we can go ahead with its inhibitors. And we have very less some paclitaxel or docetaxel, because when the progression of the disease happen, the performance of the patients is not so up to mark that the patient can able to take the chemotherapeutic drugs. So very limited options left out in the second line treatments option when the patient progress over the first line treatments, particularly the patient who has been treated with the checkpoint inhibitors in the first line treatment option. If we are coming to the side effects of the IO, then more or less we can say that the immune mediated side effects, they are the more common in this particular subset. But the side effects which higher grade, like grade 3 or more, of the side effects which lead to the interruption of the avelumab, discontinuation of the treatments, or death, they are very limited, and they are more or less similar between the placebo and avelumab arm. The side effects with the chemotherapy, they are definitely more common with the chemotherapeutic drugs, but in the maintenance, the side effects, they are very less compared to the other available option of the treatments. If we see the significant toxicity in form of the immune-mediated pulmonary toxicity, then the nivolumab is the greatest evidence of the pneumonitis. Avelumab produces the least exacerbations of the pneumonitis. Rest of the immune therapeutic drugs, they are the produce a little bit in between immune-mediated pulmonary toxicity. So if we summarize the talks, the treatment landscape of the metastatic urothelial carcinoma is evolving. The platinum-based combination chemotherapy has been recommended as a first-line treatment option, whether it's a gemcitabine plus cisplatin, gemcitabine plus carboplatin, or dosed as MVEC. Very rarely in today's era with available options of the treatments. Platinum-based combination chemotherapy has the high initial response rate, but the response is very short-lasting. The primary determining factor for selection of the treatment is patient eligibility for the platinum-based combination chemotherapy, especially the cisplatin. The switch maintenance strategy with the avelumab after the first-line chemotherapy response is the new benchmark with the OS more than 30 months and remains standard of the care. Median overall survival rate of more than 40 months has been documented with the first-line treatments followed by the second-line EV when the progression of the disease has been done with the correct sequencing. The avelumab maintenance treatments is a category 1 recommendation by the NCCN and ESMO guidelines. Other available options of the treatments, they are nivolumab plus gemcitabine plus cisplatin followed by the nivolumab maintenance therapy. Preferred regimes is EV plus pembrolizumab, but in India, lack of the availability of the EV will lead us to switch to the other available options of the treatments with the best possible result. The real-world studies, they are the consistent with the efficacy and safety profiles of the avelumab according to Javelin Bladder 100 malignancy. So I thanks for patient hearing, and I am thanks again to my organizer for giving me the opportunity to speak on this topic. Thank you.
Thank you, Dr. Kaushal. Just a small request. You have put up the point of Pembro plus EV. So what is the median OS they have achieved with the Pembro plus EV?
Yeah, I'm exactly not aware, but it is more than which we have achieved with the Javelin Bladder 100. But due to cost burden as well as due to cost burden as well as unavailability of the EV, we are not able to use these drugs because it is most efficient combination therapy with least possible toxicity. And if we see the data, then it has if we can see, then approximately progression-free survival rate is approximately 12.5 month versus 6.3 month, so that is according to the EV 302 study. And the primary endpoint of this EV 302 was the PFS, and it is 12.3 month, 5 month versus 6.3 month EV plus Pembro versus chemotherapy.
Thank you, Dr. Kaushal, for such a wonderful thing. And I feel the field is evolving day by day, and every day we are supposed to update ourselves. Just you have highlighted the role of Pembro and EV. Maybe in near future we are going to have the hand-on experience and take this talk further. Thank you once again. And may I now invite Dr. Shrikant Tiwari for frontline management of ovarian cancer. Dr. Shrikant Tiwari is consultant medical oncologist at Jawaharlal Nehru Cancer Hospital and Research Center, Bhopal. There is some change because Dr. Amit Joshi will be joining after this session. So may I request Dr. Shrikant Tiwari sir to take us forward.
Thank you, Dr. Rakesh Tan sir. Thank you for the invitation, and good evening, everyone. The topic for presentation from my side is the frontline management of ovarian cancer. So, with the overview, ovarian cancer is the fifth leading cause of cancer death in women, despite having only 1.1% of the all new gynecological cancers. The 5-year survival is only 49% overall, and in distant metastatic patients, the 5-year survival is even much lesser, is around 30%. The 57% of women diagnosed usually in third stage or fourth stage, and median age of the diagnosis is around 63 years. The treatment overview, as we know, the frontline treatment is in the form of surgery if the patient's conditions permit and the surgeon skills permit that the resectability is possible, then a front surgery followed by adjuvant chemotherapy, or if the tumor burden is very high or due to the poor performance state of a patient, if the surgery is not possible upfront, then neoadjuvant chemotherapy followed by interval debulking surgery is the main treatment. After then, adjuvant-based chemotherapy, the frontline maintenance therapy or observations are the options. Later on, if relapse happen, then the treatment of recurrence and metastatic setting and maintenance in the recurrence setting, that will be discussed later on. So my scope is from the surgery to the maintenance therapy. What are called the frontline treatments? Go before. Just before slide. Yeah. So response rate is around 80% in the frontline chemotherapy. But the green part of the ovarian cancer is that the relapse rate are very high, and it occur in almost 70 to 90% of women with advanced stage in first 3 years. So the median PFS is around 18 months. So I will not going to discuss about the surgery, whether it's the primary cytoreductive surgery or interval debulking surgery. So the frontline treatment, I am going to discuss about the chemotherapy, then the targeted therapy, that means the bevacizumab, then the further targeted therapy is the PARP inhibitor, and is there in role of any immunotherapy is there or not. Next. So for the if you see the treatment overview of the ovarian cancer in last 2 decades, so the first decades was the fully dependent on the chemotherapy, and the paclitaxel carboplatin was the backbone of chemotherapy. After all the different landmark trials, it was seen that the paclitaxel and carboplatins became the standard of care if you compare the efficacy as well as the toxicity in compared to the other chemotherapy. But after that, there was no improvement happens in the frontline management of the ovarian cancer. So multiple variations of the chemotherapy was done: intravenous chemotherapy, intraperitoneal chemotherapy, dose-dense chemotherapy, continuation of maintenance chemotherapy, multiple permutation and combination was given. And the landmark trial for intraperitoneal chemotherapy was the GOG 172, and it has shown a significant the PFS benefit in intraperitoneal chemotherapy group of patients. But the significant tolerability was an important issue. And with the development of after the 2012, with the development of the bevacizumab, the intraperitoneal therapy now has limited role or almost have no role, and that was proven by this GOG 252 study, which has shown that if patient has been taken intraperitoneal chemotherapy versus intravenous chemotherapy plus bevacizumab, the result, there is no much difference in the result, and the tolerability and safety profile is much better in intravenous plus bevacizumab in compared to intraperitoneal chemotherapy. Next. The dose-dense chemotherapy, the multiple dose-dense chemotherapy site, the protocol was made, and the treatment was given to the patients 80 milligram paclitaxel or 60 milligram paclitaxel weekly. And it has been seen that after all the trials, been seen that the 3-weekly chemotherapy has the equal efficacy and compared to the dose-dense chemotherapy. There is no extra benefit of using dose-dense chemotherapy. The drop rate of in case of dose-dense chemotherapy is much higher in compared to the conventional 3-weekly chemotherapy. So still the 3-weekly paclitaxel carboplatin based chemotherapy is the standard of care. There was one trial, that is the ICON 8B trial, that has suggested if weekly dose dense chemotherapy plus bevacizumab versus 3-weekly chemotherapy plus bevacizumab. And if you see the result, next please. If you see the result of this, the ICON 8B trial, those patients who have received dose dense weekly chemotherapy plus bevacizumab, the median PFS is almost 5.5 months more in compared to 3-weekly chemotherapy plus bevacizumab. So it was concluded that that chemotherapy regime can be used in stage 3 and 4 high risk of patients. Otherwise, 3-weekly chemotherapy is more or less the similar result. After chemotherapy, the next drugs which used in the frontline management of the ovarian cancer is the bevacizumab, and multiple landmark trials has been done for that to see the efficacy and safety of bevacizumab containing regime. One of the important trial was the Anthelia trial, and the purpose of this trial was to see whether the addition of this bevacizumab to paclitaxel carboplatin based chemotherapy can we achieve maximum cytoreductive surgery or not. And the result of this trial shows that if bevacizumab has been added with the paclitaxel carboplatin based chemotherapy as a neoadjuvant setting, so in interval debarking surgery, the complete cytoreductive surgery has been achieved much more in compared to without bevacizumab. Another important trials, I am going very short of these trials. This the GOG 218 trials, the overall survival subset analysis, it has been seen that in stage 4 ovarian cancer of patients, where the bulk of disease are very high, there is 10-month overall survival improvement is there if bevacizumab added in the paclitaxel carboplatin regime, and there is additional 19% reduction in the risk of death happen in such type of patients. The similar data has also been shown. Next. The similar data has also been shown in case of the ICON 7 trial. That trials, the final, if the see the subgroup analysis of the overall survival data, in stage 4 high risk patients, the benefit is there, the PFS benefit is there of using this bevacizumab containing regime along with the chemotherapy. Next. Similar data is there. Next. Yes. So after the frontline chemotherapy and this bevacizumab containing regime, the next line of treatment which we are using in the first line setting is the PARP inhibitors. And the PARP inhibitors we are using in the either in those patients who are in the BRCA mutant or HRD deficiency is there. Next. So the BRCA mutations and HRD are very common in ovarian cancer. And if you see the BRCA1 and 2 mutations, it is seen in almost all variety of ovarian cancers, whether it's the serous high grade or low grade, endometrioid variety, carcinosarcoma, clear cell sarcoma, or transitional cell sarcoma. Around 50% of high grade serous ovarian cancers show HR deficiency. Out of this 50%, around 22% are contributed by germline or somatic BRCA mutation, and rest 25% are by other genetic mutations or methylations are there, which contribute to HR deficiency. The testings, the most common testing method which is recommended and is used in most of the landmark trial of the PARP inhibitors are this myriad, my choice HRD. And the second one is this Foundation 1 LOH that has also been studied in Ariel 3 trial as well as the Athena mono trial. So these are the different randomized study, and the patients have been categorized whether the patient is BRCA mutants or BRCA wild type with HRD positivity or BRCA wild type with HRD negativity. Whether we are using PARP monotherapy as a maintenance, PARP plus bevacizumab, and PARP plus immunotherapy along with or without bevacizumab. So I'm going to discuss all these trials one by one detail in short. So the first set of patients is the those patients who are having BRCA mutation positive. There are three important trials for PARP monotherapies. The solo one for olaparib. Next slide, please. Yeah. If you see the result of this trial, the solo one trials, the median PFS has not reached versus 13.8 months with a hazard ratio of 0.30. In case of Prima, the hazard ratio is 0.40. And in case of Athena mono, again, the hazard ratio is 0.40. So those patients who are having BRCA mutation positive, the PARP inhibitors monotherapy maintenance has excellent response with the median PFS is not reached in the solo one and Athena mono trial, and in Prima trial also the median PFS is around 22.1 months compared to 10.9. In the 7-year follow-up data of the solo one trial, if you see the overall survival data, the median overall survival is around 75.2 months in placebo group, whereas the overall survival has still not reached in case of the olaparib group. The time to first subsequent therapy which need to be started is around 64 months in olaparib group, and in placebo is around 15.1 months. So if you compare this data, so the time to first subsequent therapy has been started almost 4 times later than in olaparib arm compared to the placebo arm. The 3.5 years follow-up data of the Prima trials, again, if you see the median PFS in BRCA mutant positive patients, the median PFS is around 24.5 months in case of niraparib versus 11.2 months in case of placebo. Next. The Paola trials, where they have used the pooled data of the BRCA mutant positive patients, where this olaparib has been used along with the bevacizumab. Show me the data. Yeah, so the primary analysis, the median PFS in Paola trial in those patients who are having the BRCA mutants positive, the median PFS is around 37.2 months in olaparib plus bevacizumab versus 21.7 months in bevacizumab. The overall survival, the OS data is around 77. Just go before. Yeah, the OS data in case of in Paola trial in those patients who are having BRCA mutation positive is 75.2 months in olaparib plus bevacizumab and 66.9 months in case of only bevacizumab. And all these data are significant. Next. Now, the second group of patients in whom the tumor BRCA mutations are wild type, but HRD test was positive. The solo trial was they have included only BRCA1 mutation positive, so they had their data has been out from this subgroup of patients. So the Prima trial and Athena trial, they have used the BRCA mutant, BRCA wild type and HRD positive. And if you see after 3.5 years of a follow-up data, the median PFS is around 19.4 months in case of
Shrikant sir, kindly conclude. We are running out of time.
Okay. Just give me 2-3 minutes.
Sure, sir. Sure.
Yeah, okay. So 19.4 month in case of in prime 19.4 month versus 10.4 month. Whereas in Athena mono trials for niraparib, it is 20.3 month versus 9.2 months. The OS data has not been matured for the prima and Athena mono both. Next. In the Paula 1 trial, again, those patients who are having BRCA wild type and HRD positive, in this case, again, the PFS data is quite significant in favor of this PARP inhibitor plus bevacizumab. Next. Now, in third group, subgroup of patients where the BRCA is wild type as well as the HRD tests were also negative. Go. Yeah. So in those patients who are having BRCA wild type and HRD negative, if you see the data, there is no much difference in the data. So median PFS is on primary analysis of prima trial, the median PFS is around 5.4 months versus 8.1 month. Or after 3.5 year of follow-up, it is 5.4 months versus 8.4 months. Whereas in Athena mono trial, again, it's 12.1 month versus 9.1 month with the hazard ratio of 0.65. Next, please. In Paula 1, again, the data is more or less similar. So there is no benefit of adding PARP inhibitor in those patients who are having BRCA wild type and HRD test negative over the bevacizumab alone. Next. This is the another trial, Overview trial, where the niraparib has been used along with the bevacizumab. Again, the data is more or less similar to the Paula trial. Like this olaparib plus bevacizumab, the data is more or less similar. The PFS is in favor of niraparib and bevacizumab in those patients who are being HRD positive. But in those patients who are in HRD negative, there is no benefit of adding niraparib along with the bevacizumab. Next, please. So this is, let's go next. Now, in the role of immunotherapy. Next, please. Yeah. So, so if you see the frontline management of the ovarian cancers, we have started with the chemotherapy, and for 1 decade, the chemotherapy was the only backbone of treatment. In 2011, the first paradigm shift happened when the bevacizumab was introduced, and it was used in the ovarian cancer along with the chemotherapy. The second paradigm shift happened with the result of solo trial, where the olaparib was used in BRCA mutant positive patients. And the third paradigm shift in the management of the frontline management of ovarian cancer happened when this the result of this the prima trial, Athena mono trial, and Paula trial has been shown a significant benefit of using either PARP inhibitor alone or PARP inhibitor along with the bevacizumab as a maintenance in BRCA mutant or HRD positive patients. And we are waiting for the fourth paradigm shift to happen. Next, please. Next, please. Yeah. So next, go next. The important going on trials. Yeah. So this duo O trials are important trials. They have it's the phase 3 trials, which includes the patient and randomized into 3 arms. The arm 1 was including the chemotherapy bevacizumab with durvalumab placebo. Arm 2 chemotherapy bevacizumab plus durvalumab, and arm 3 chemotherapy bevacizumab plus durvalumab, and in maintenance in arm 1 bevacizumab, only bevacizumab maintenance with durvalumab placebo and olaparib placebo. In arm 2 bevacizumab durvalumab with olaparib placebo, and in arm 3 all 3 drugs have been used. The primary endpoint of this study was to assess the PFS in arm 3 versus arm 1, and secondary endpoint was to assess the PFS in arm 2 versus arm 1. Next, please. So in the patients which have been included are the non BRCA negative but HRD positive patients, and in HRD positive patients, if the bevacizumab was used along with durvalumab and olaparib, the median PFS was around 37.3 months versus 23.3 months with the hazard ratio of 0.449. Next. Yeah. In intentions to treat populations in the overall populations, whether HRD positive or negative, again, the median PFS is around 24.4 months versus 19.3 months in favor of the combination of immunotherapy, PARP inhibitor plus bevacizumab. Next. Next, please. On subgroup analysis of HRD on the HRD status in arm 1, 2, and 3, if you see in those patients who are having BRCA negative but HRD positive, the benefit is there of adding PARP inhibitor along with the durvalumab and bevacizumab. But in those patients who are having HRD negative, the use of bevacizumab, PARP inhibitor plus durvalumab has some benefit, but using bevacizumab plus durvalumab has shown no benefit. Next. These are the completed frontline trials of immunotherapies. The results will be, I hope, will come in the next year. Next. So I am hoping that the next paradigm shift happen in 2025. Thank you.
Thank you, Dr. Shrikant Tiwari, sir, for taking us through frontline management of ovarian cancer. As we are running some short of time, I would like to invite Dr. Amit Joshi, sir, for Dr. Amit Joshi, sir, is a professor, head in medical oncology, Tata Memorial Hospital, Mumbai, and he's going to comment us or take us through the management of clear cell metastatic RCC. So may I request Dr. Amit Joshi, sir, to start, please?
Can my slide visible? No.
Yes, sir. Your slides are visible. Kindly make it full screen.
Not. Is it full screen now? Can it's visible? Rakesh, can you see my slides?
Yes,
Slide
sir.
visible. The only thing is it's not on the slide.
Full screen mode.
Yeah, I have done the full screen. It is not.
No,
Now it's full screen.
No, it's not.
Just wait 1 minute. Wait. Is now full screen?
No.
I'm not sure I'm sharing this. So this is the screen. And I start share.
Sir, kindly click on slideshow. You can show on that like home, insert, design, animation, slideshow.
This is the slideshow.
Yes, now it's visible, sir.
Now it's visible.
Perfect.
Yes, sir.
Perfect.
Yeah. So I think we'll just quickly run to this RCC management. So generally, the metastatic RCC patient presents with a history of painless hematuria, and when further workup, they usually by a USG find a lesion in the kidney, and then on further workup find to be a renal mass with multiple lung metastasis, and that is the usual way the RCC usually presents. And then when we do the initial workup, when generally the patient goes to the neurosurgeon, and then when on metastatic workup they find that there is a metastatic lesion apart from the kidney lesion, generally they refer us to until unless the hematuria is of a very great extent, the patient usually referred to us. Then we have to take a call regarding the therapy. So if the cytoreductive nephrectomy has not been done, then definitely we need a biopsy. And this is the general way these patients are renal mass with a multiple lung metastasis. So then the question will come, how to proceed in a patient of a upfront metastatic RCC presenting with the renal mass and lung mets. So the question which is being very commonly discussed previously, whether the cytoreductive nephrectomy is advisable in a patient not presenting with a gross hematuria or abdominal pain, where to place the cytoreductive nephrectomy. Do all patients need a metastatic patient need a kidney removal, or we can wait for that? So to answer this question, so this question was initially in the what we call as a TKI era, when the sunitinib, pazopanib, or other TKI were used in the first line. So there are two trials which tried to look in or try to give the answer for this question, whether the cytoreductive nephrectomy in a metastatic patient is really improving their survival or not. So if you see the overall what we call as IMDC database, so it's a pooled database of all the patients who have metastatic disease and undergone cytoreductive nephrectomy before the starting therapy. So this is not a randomized trial. This is a pooled data of all patients. So what this paper concluded, that patient who received cytoreductive nephrectomy before starting the treatment has a better OS of 26 months, 20.6 months compared. But definitely there is a bias in this data. Those patients who are not fit for surgery because of their general condition might not have offered the cytoreductive nephrectomy, and those who are on a fitter side might have offered. So this might lead to a bias, and probably this may be the one explanation that the cytoreductive may be beneficial, but there is no randomized trial to answer this question. So to address this question, there were two randomized trials were done in around 2015 to 20 era, where the question of this was addressed. One was the what we call as Certime and the Carmina trial. These are the two trials which try to look into the answer to this question, whether a patient of a cytoreductive nephrectomy is needed or not. So in this study, what we can conclude from these two trials, that is Certime and Carmina trial. So little bit different design. In Certime, the patient were immediately underwent cytoreductive nephrectomy, followed by sunitinib, versus 3 months of sunitinib followed by nephrectomy. So if you look to the result of this trial, of both trial, indirectly both trial concluded that in patients of a metastatic RCC, not much symptomatic for hematuria, doing a upfront cytoreductive nephrectomy has not shown survival benefit. What they concluded from this both papers, although the trial design was little bit different, but they concluded that in patients who are fit for starting the therapy, it's best to start the TKI and then wait for a few months. If they respond well, their disease remain well controlled, then what we can conclude that interval cytoreduction may be a better approach rather than subjecting all patients for cytoreductive upfront. So in the TKI era, both trial had concluded that in patient of a metastatic RCC, upfront cytoreductive nephrectomy is not needed. Start the TKI because it's a metastatic disease. Those patients who are doing well after 8 months, 6 to 8 months, then our rediscussion regarding the cytoreductive nephrectomy can be considered. So this was the answer given in the TKI era. Whether this is applicable in the immunotherapy era, that is still unanswered. So, so if you look to the Certime trial, patients who receive the deferred nephrectomy has a better survival compared in patients who receive the immediate cytoreductive nephrectomy. So this question was clearly answered for a TKI era. Whether this cytoreductive nephrectomy in immunotherapy era is needed or not, that question is still in a randomized way, is still there are trials going on. One big trial that is known as PROBE trial is probing the role of cytoreductive in advanced renal cell RCC. So if we are planning a pembrolizumab plus axitinib or pembro plus len, do we need to do nephrectomy in all patients of metastatic? That question is still unanswered. The trial is just concluded its accrual, and in next one and a half year we may be able to. So till this point of time, when patient comes to us not much symptomatic, we start the IO plus TKI, wait for few months. If there is a very good response in metastatic side, then in case-to-case basis we consider for a cytoreductive nephrectomy as per the response of the treatment. But is there any randomized trial to answer? No, this trial is going to answer this question in immunotherapy era. So I think we have to wait for a randomized trial for this. So is there any place of some sort of immunotherapy with a local treatment in a metastatic condition? So this is one of the phase 2 study in patients of a metastatic RCC with limited metastatic disease, that is 1 to 5 metastatic disease. This is one phase 2 trial, and it is more relevant to our scenario, where the immunotherapy is very costly. Can we consider a limited duration of immunotherapy with radiotherapy? So this is the Rappaport trial, which I have given this answer, although it's a phase 2 study in this patient of a oligometastatic disease, that is 1 to 5 metastatic with clear cell RCC, patient, the radiotherapy to the metastatic site with 8 cycle of 200 mg of pembrolizumab every 3 weekly, and the survival was this is equal to that. So in patients who are not affording for a very long duration of immunotherapy, oligometastatic, amenable for radiotherapy, at least the SBRT, we can consider for a limited duration in case basis, giving the immunotherapy for 8 a cycle and then we stop. So this is one of the phase 2 data for a limited use of immunotherapy in a metastatic with SBRT. So we consider in patients who are not affording with limited disease. So SBRT and short course of pembrolizumab in a oligometastatic RC is well tolerated with a durable response and good local control. Up coming to the systemic therapy in clear cell metastatic RCC, as we all know, with the availability of the immunotherapy in TKI, this field is very rapidly evolving, and there are at least 4 or 5 randomized trial of immunotherapy with TKI or immunotherapy with other immunotherapy are in that. So it's very difficult choice what to offer. So whether to give them IO plus IO, whether to give them the IO plus TKI. So there are some merits and demerits of each and individual treatment option. So we will just quickly look towards the data for IO plus IO or that is ipilimumab plus nivolumab or Pembro XZ or Pembro Lenva or Nivo Cabo. So we'll not go in detail, but we'll discuss some practical points in selecting the treatment. So if you see, there are 1, 2, 3, 4, 5 trials are there, except the Javelin trial, which is a negative study. So all this Checkmate 214, Keynote 426, the Checkmate 9ER and Clear. These are the trials which have established the definitive role of immunotherapy with TKI in first line. So one thing is clear, in patients who are affording for the immunotherapy, the single agent TKI is practically out. The combination of immunotherapy, and that combination can differ as per the physician choice, what are their experiences with the immunotherapy and with the use of immunotherapy plus immunotherapy. So except the avelumab plus axitinib, all other were positive trial in this scenario. So this is the trial of what we call as Checkmate 214 Ipi-Nivo in a metastatic clear cell RCC, Nivo Ipi versus sunitinib. So sunitinib was the standard of care and against the Nivo Ipi compared. So if you see, this is the longest follow of any immunotherapy trial. So if you see the result of this trial, this is the OS data, and in the month axis, if you see, they have reported 90 month. So 90-month follow-up. So that means close to 7 years. So this number was previously unheard, that in metastatic RCC, we can think of a 7-year follow-up. So if you see the Nivo EP, the median overall survival in combination of Nivo EP is close to 53 months. Median OS 50. That means 50% patient who receive Nivo EP in a metastatic clear cell RCC scenario are still alive after a, or more than 50% patient are alive after a follow-up of 52 months. Whereas in sunitinib, this was close to 30. So there means that it looks like to be that there is a clear-cut doubling of a survival of a metastatic RCC patient when they receive some sort of a immunotherapy. So with this trial and with this data, we are looking towards the 8 or 9 year follow-up survival in a metastatic setting. So this is very updated data. So if you see the curve, around 35% patients after a follow-up 90-month follow-up are still alive in a metastatic RCC who receive immunotherapy. So this number were previously unheard for any metastatic. At least in RCC, we can't think of a 35% survival at 90 months. Similarly, the PFS was also better in the Ipi-Nivo arm compared to the sunitinib arm. So with this trial data, the immunotherapy has again established its role in management of RCC. So if you see the other parameter of this trial in both intermediate, and we all know that when we start the treatment of metastatic RCC, we divide as per the IMDC criteria depending upon the various risk factors. And the other important thing for this 8-year follow-up data is that previously we used to thought that intermediate and poor risk only benefited, but on long-term follow-up, if you see the complete response seen in the favorable risk, it's close to 12% compared to the 6%. Similarly, the ongoing complete response also, that means not only the intermediate and poor risk, probably the favorable risk group, which was not previously included, is getting benefit with the Ipi-Nivo data, and the guideline may change in future that all patients may be offered combination of at the start of the treatment with the long-term data of this. So is there any hindsight of this Ipi-Nivo combination? So the only thing is that when we compare with the Xi plus Pembro, the only problem with the use of Nivo Ipi is that some patient. So if you look towards this control rate, the only negative point is that the progressive disease was seen as a first response in quarter of the patient, whereas in progressive disease was seen in only 15%. So there is one-fourth probability that when you start the Ipi-Nivo, one-fourth patient may progress without a response. So we have to take a clinical call whom we offer Nivo plus Ipi compared to the Pembro XZ or Pembro Nivo or Nivo Cabo. So in patients who presents with a large volume of the disease where we need a very early response, patient presenting with a large pleural effusion or a metastatic liver disease which is compromising the patient's general condition, where we can't rely or we want an early response, we generally prefer a combination of IO plus TKI. But when the disease volume is not too much, like a multiple small lung nodule, we may still consider for giving them the Ipi-Nivo, because the Ipi-Nivo, the immunotherapy takes some time to act, because there is such no VGF TKI in that combination which can directly kill the tumor cells. The body's immune system which is going to change, and that will take time. So in patients of a symptomatic high volume disease, IO plus TKI is preferred, whereas in patients with a low volume metastatic disease, not much symptomatic, where we can wait, we can consider for a Ipi-Nivo, because the survival of a Ipi-Nivo in those patients who respond, there is a good probability that the patient will respond. So these are the trial which I just compared, the Len, Pem, Xi plus Pem, Ipi plus Nivo, and Nivo Cabo. So these are the two studies. If you see the various parameters and response, the Ipi-Nivo in terms of long-term overall survival stands out compared to the Len Pembro or Xi plus Pem or Nivo Cabo. But definitely the choices are different in terms of PFS. Len Pem was far better with in Len plus Pembro arm. The PFS is 24 months compared to the 15.4 months. Similarly, the discontinuation rate, if you see, the discontinuation rate was highest in the Ipi-Nivo, 23%. So that means each combination has its plus minus point. What suits to the individual patient, that need to be discussed. Like in patients who have a brittle diabetic, where we know that the patient may need a steroid after using of the immunotherapy, we might not prefer. In elderly patient, the combination of a Ipi-Nivo may lead to much more toxicity. So individual choices will depend upon the other patient related factors also. So if you so the question comes that what we discussed, that decision making for intermediate and poor risk. So if what we discussed, that if there is a rapid deterioration is suspected, we generally do not prefer the Ipi-Nivo. We consider Xi Pembro or Pembro Len or Nivo Cabo. Patients who are having a already some sort of immune related problems, or they are already on the steroid, we usually avoid the Ipi-Nivo, because in that study 25 to 30% patient needed steroid for management of immune related toxicity. So this is the just a chart which is showing the how the survival has improved over period of time. So if you use the response rate compared to the sunitinib, which was the standard of care at that point of time in 2010, the response rate was only 27%. And if you see the over period of time, this has increased. And in the Xi Pembro and the Nivo Ipi, the response rate is clearly doubled. So that means in last 1 decade, the management of RCC has improved over period of time, and the newer combination has definitely improved the survival in compared to the TKI alone. And this chart predicts the same, that response rate is clear cut doubling in the response rate of various TKI. So 27 to 59%. If you compare the median PFS, this is the median PFS seen in the sunitinib, close to 9 months. If you go down the line, the median PFS is increased, and in the Pembro length, that is a close to 24 months. So compared to the TKI, definitely the PFS has improved over. There is another in between the data of availability of a triplet therapy. So Ipi-Nivo plus Cabo. So people, the investigator tried to combine 3 drugs, Cabozantinib plus Nivo plus Ipi. Although we all know that handling 2 drugs is a difficult situation, then managing a toxicity of 3 drugs may be very, very difficult, but still the investigator tried, and the PFS of this is showing the superiority over the Nivo plus EP, but long-term OS data is available. So if that OS or overall survival is positive in the triplet arm, the combination of ipilimumab, nivolumab plus cabozantinib may become a standard of care. But at this point of time, the data is not matured. The PFS seems to be better, but OS data is still yet to mature. So we have to wait for this triplet combination. But as discussed, the combination of triplet, the toxicity may be more. Regarding the, so this was the mainly for the intermediate and poor risk. So if you see the good risk patient, as we discussed previously, the combination of the pembro plus XZ versus pembro plus lenvatinib or nivo EP, if you see the survival for these good risk patient, the pembro XZ might not have benefited too much in terms of PFS or OS. The choice for a good risk patient may remain the pembro lenvatinib or Nivo plus cabozantinib, and now with the what I discussed, that the data of the ipi-nivo is also. So pembro XZ is usually not preferred in a good risk patient because it has not shown even the PFS benefit in the early stage of the disease. That what we discussed, that in the good risk scenario, either pembro lenvatinib or nivo plus cabo seems to be the better choice compared to the pembro plus XZ. The other important point about the RCC with sarcomatoid feature. So when we see the histopathology report of RCC in around 10 to 15% patient, we may see there is a sarcomatoid features. So if you see the data for this, all the checkmate 214, that is ipi-nivo, keynote 426, that is XZ pembro. So the percentage of sarcomatoid varies from 18 to 20%. If you see the response of a complete response, patient who receives some sort of a immunotherapy. So patients who have the sarcomatoid feature in ipi-nivo, 23% patient receives a complete response, which is much more than the, in XZ it is close to 12%. In Nivo, it is close to 15%. So that means the any percentage of sarcomatoid in RCC usually prones the or puts the patient where the benefit of immuno comes. So RCC with sarcomatoid, we have to use immunotherapy either in a combination with other immunotherapy or with a TKI, because if you see the responses, that is much better compared to the conventional clear cell RCC. So this was the discussion that where to use. If patient is not affording for immunotherapy, then this is one of the trial of cabozantinib, which is scenario in our majority of the patient, where patient is not affording for immunotherapy, then cabozantinib versus sunitinib. So this was the cabo-sun trial. And in patients who are intermediate and poor risk, cabozantinib versus sunitinib were compared. And in this trial, the median OS was favoring the cabozantinib arm compared to the sunitinib. So if the patient is not affording for immunotherapy, intermediate and poor risk, cabozantinib has shown benefit in terms of overall survival of 30 months compared to the sunitinib. So intermediate and poor risk, cabozantinib alone is the patient not affording immunotherapy, it is a superiority over that. But definitely the toxicity of cabozantinib is much more than the sunitinib. So in some patient, we don't start with 60 mg, we start with 40 mg, and if they're tolerating, after 4 to 6 weeks, we increase the dose, because with 60 mg, the toxicity is too much. If you see the grade 3 or 4 toxicity is seen in close to 66% patient in a trial setting. So in day-to-day setting, you just add the number by 10, 15. So that was the discussion regarding the intermediate and poor risk patient of a clear cell RCC. So what we discussed about previously was the clear cell RCC. What we do in non-clear cell RCC, there is no one standard regime. The suggested regime may include the lenvatinib plus everolimus, or a single agent nivolumab, or cabozantinib is also used. So the use of a immunotherapy with TKI, all the randomized trial is in the clear cell setting. Non-clear cell setting, still either the cabozantinib can be used or a combination of pembro plus. So there is no one standard regime for non-clear cell RCC compared to the clear cell RCC. So this is one of the trial which we have discussed regarding the use of various combination. Only phase 4, phase 2 data is there of use of pembro plus XZ. I think with the in the interest of time, I think we'll just conclude with this, that patient in the. So I will just conclude two slides, and then we'll wind up the discussion. So as we are seeing that in patients of a metastatic clear cell RCC, like in any other lung cancer, if we deal today with the lung cancer, we don't treat all adenocarcinoma with one bag. We know that the EGFR mutated, ALK mutated, ROS mutated, the RET mutated, all they have a different course of action. Similarly, breast cancer. So similarly, the molecular subtypes are coming in a big way in RCC. So in next 3 or 4 years, like lung cancer, we send the sample for mutation. Similarly, we will send the sample for a looking towards the whether it's an angiogenic tumor or a T effector tumor. So this is the next future for RCC, that all patients are not treated with TKI or IO or IO. That will, and which patient is going to respond to the one particular therapy, the molecular pathology or the molecular marker will decide whether the patient is going to respond to the TKI or a TKI plus IO or IO plus IO. So the trials are already ongoing, and next 2-3 years we may have a molecular data. So this is the last slide. So this is showing the how the treatment has improved over period of time. So this is the overall survival in this axis, and this is the time over period. So this first graph is for interferon era. So if you see in interferon era, hardly as the follow-up time increases, very rarely any patient used to survive. Then this is the green line of a TKI era. So at 3 year, when patient started on TKI, at 3 year, close to 30% patient or 35% patient were used to be alive. Whereas with the IO, this number has greatly increased. So in the IO era or IO TKI era, around more than 70% patient, and this is of a metastatic RCC. So if you see the curve which is flattening has started, what we call as a tail of the curve. With the immunotherapy, the tail of curve like this has started. So we are at this point of time that with the IO plus IO or TKI, 50-60% patient are getting controlled, may be called as a cured, like a CML, where we use imatinib. And this is the future goal, that all metastatic patients which are diagnosed, hardly the curve will show any flattening, and all patients like a hypertension and diabetes, their time will come where all metastatic patients will be practically controlled with the available therapy. So we are at this juncture, and this gap, but as the science are moving in next 5-10 years, all metastatic patients may remain alive with the treatment. So with this I will end, and I think that this is just the last slide that I will show, and we will end with this. Thank you, Rakesh, for this opportunity to discuss this with you.
Thank you, Dr. Amit, to taking us through the journey of metastatic RCC, which was, as you had rightly said, started from our DM time when it was interferon.
Yes, we use interferon also in our DM time.
Then it moved to sorafenib, then sunitinib, and so on. And we are lucky enough to see the curves getting separated and getting uplifted.
Yes, and flattening of the curve.
Very true, very true. It was really wonderful to hear you, as always. Very, very crisp and straightforward things to remember and to practice. Thanks a lot, Dr. Amit.
Thank you.
May I now invite, as Dr. Kirpa has joined, may I request Dr. S.P. Srivastav to please continue with the next session. And meanwhile, we try to connect with Dr. Kirpa for the panel discussion. So Dr. S.P. Srivastav, as we are aware, is a head and director of medical oncology at Kokilaben Dhirubhai Ambani Hospital, Indore. And he's going to take us through a short journey. I request for a short journey because we are already running late. So a short journey for a preferred approach in the management of CINB with Newpitent, Netopitent, and Pelonosetron tablet. Dr. SP, please.
Thank you once again, sir. And I will definitely try to just make it short and sweet in the benefit of time. So it is regarding the day-to-day issue what we face in our clinical practice, that is the chemotherapy-induced nausea and vomiting and radiation-induced nausea and vomiting. That is very important to discuss as well. So today my presentation would be on the preferred approach to improve CINV prophylaxis with combination of netopatent plus palonosetron, which is truly effective. So if we start with the incidence of chemo-induced nausea, vomiting, and radiation-induced nausea, vomiting, so approximately the nausea was on the higher side or higher percentage as compared to the vomiting. It is 60% of patient reported nausea alone, and which we usually see it is a great or major issue or in our continuation of treatment. So these are the guidelines which has been given by the MAS and ESMO for on the basis of emetic risk. So they have classified emetic emesis risk on high, moderate, and low and minimal. High, it is more than 90% of patient are having a risk of emesis. Moderate is 30 to 90%. Low is 10 to 30%, and minimal is less than 10%. So this is the classification or division of the chemotherapeutic agents based on high, moderate, low, and minimal. So I think so everybody is aware about all these molecules because day-to-day clinical practice. So if we see the what are the anti-emetic we can use or what are the recommended in high non-adriamycin cyclophosphamide, high adriamycin cyclophosphamide emetic risk patient. So four drug combination 5-HT3 dexamethasone, NK1 inhibitor, and olanzapine, which we are commonly or routinely using. When there is a moderate like oxaliplatin AUC5 and carboplatin AUC5 and oxaliplatin in women of less than 50 years, then three drug combination we can skip the olanzapine, and but sometime in our clinical practice we can use also because this is a wonderful drug to add to reduce the percentage of nausea. Moderate, other than the carbo and oxaliplatin, two drug combination can be used like 5-HT3 inhibitor and dexamethasone. And in low cases, any one of them like only 5-HT3 antagonist, dexamethasone, or dopamine receptor antagonist can be used. So this is the summary of for the acute nausea and vomiting as per depending on their risk categories. When we go for delayed nausea and vomiting, then in the cases of high non-adriamycin cyclophosphamide, olanzapine plus dexamethasone can be used, and high adriamycin cyclophosphamide, olanzapine alone, it is very useful for the delayed control of nausea and vomiting. If we go for moderate, low, and minimal, then in that cases for delayed, there is no prophylaxis is recommended. If we go for the recommendation of prevention for nausea and vomiting patient receiving high dose chemotherapy, so level 1 evidence to use for a combination of 5-HT3 antagonist plus dexa plus NK1 antagonist before chemotherapy. Olanzapine can be added, and for breakthrough nausea and vomiting, we suggest the olanzapine if not previously used as prophylaxis. The dose is 10 milligram OD for 3 days, but in our clinical practice, we use it as a 5 milligram. Recommendation of olanzapine doses, it is a level 2 evidence. There was a comparison between 10 milligram and 5 milligram, but 5 milligram shows the similar efficacy is compared to the 10 milligram, and without increasing the chances of sedation and sleepiness of the patient. So we usually go for 5 milligram, and sometimes we can go for 10 milligram if patients are not responding. For radiation therapy, there are again recommendations as per the risk level, like high, moderate, low, and minimal. High is total body radiation, which we usually don't face in our clinical practice because it is specifically recommended for certain indications. Moderate is upper abdominal and CSI, craniospinal radiation. Low for brain, head and neck, and thorax, and minimal for extremities and breast cancers. So the recommendation for prevention of acute nausea and vomiting patient receiving concurrent chemotherapy, that is weekly cisplatin 40 milligram. That is again a combination of 5-HT3 dexa and fosaprepitant or aprepitant. So it is a three drug combination regimen can be used. It's a level 2 evidence, but And the recommendations for delayed nausea and vomiting patient for radiation therapy, when we are using concomitant cisplatin 40 milligram per meter square, it is again, it is a we can use 5-HT3 antagonist, dexamethasone and fosaprepitant combination. So there are some studies which on the basis of these studies we go for the continuation of antiemetic therapies. So it is a ESCO 2002 study where they have taken 191 patients, and predictive score was considered on the basis of these criteria: hematogenic potential of therapy, educational status of patient, nausea and vomiting due to other medications, motion sickness, anxiety from therapy in general, anxiety from nausea due to chemotherapy. So here it is the pharmacological mechanism of netopatent plus palansotron, which is a combination, Nicron, and it is working on multiple pathways. One is the serotonin and another one is the substance P pathway. So palansotron is having a pathway on the basis of 5-HT3 receptor inhibition, where it also inhibit the crosstalk between the NK1 and the 5-HT3 receptors. Netopatent palansotron combination enhance inhibition of both serotonin and substance P, and palansotron enhance the prevention of delayed emesis by inhibiting the NK1 receptors. So NEPA, it has a synergistic effect, provide prophylaxis against CNV in both acute and delayed phase. If we see the efficacy wise, we see the NK1 receptor antagonist, that is the netopatent, half-life is having 96 hours, and aprepitant is 9 to 13 hours. Here only the palansotron or ondansetron and granisetron, and palansotron is having highest half-life is the 40, more than 40 hours. So netopatent is having almost more than double of the half-life. So it prevent the CINV for longer period of time as compared to the 5-HT3 antagonist only. So if we see the data on efficacy of netopatent and palansotron for highly emetogenic chemotherapy, that is the study in published in ESCO 2021, where they have compared NEPA plus NEPA with aprepitant. So they have assessed the duration of breakthrough chemotherapy-induced nausea, vomiting. It was a pooled analysis, and finally concluded with the single-day NEPA is more effective than 3-day aprepitant in preventing delayed CINV, and it is more effective in minimizing the extent and duration of CINV in patient with breakthrough MSS, nausea, vomiting. So chemotherapy-induced nausea, breakthrough nausea and vomiting, in both the ways, the NEPA was a better choice as compared to the fosaprepitant only. This is the real world data. Here we can see this by using the NEPA, the fear occurrence of nausea and vomiting and fluid electrolyte imbalances in every cycle of the chemotherapy. So it is the only, not only the highly effective but also a convenient guideline compliant antiemetic agent as a fixed single dose prophylactic antiemetic combination given with dexamethasone before chemotherapy. So NEPA is having a netopatent and palansotron having a clear-cut benefit over the only palansotron. What we have the Indian experiences of this combination. So where we can see, this is the study published by Swaha Sagar in 2023, where they have done a retrospective evaluation of DEXA sparing antiemetic regimen and antiemetic prophylactic study on NEPA for preventing chemotherapy induced nausea and vomiting in cancer patients. What they have found, dexamethasone in its dose of 8 to 12 milligram was administered on day 1. Only for each cycle was combined with tablet netopatent 300 milligram and tablet palansotron 0.5 milligram. The brand name is Nicron for this, 1 hour before the start of highly emetogenic chemotherapy. So these were the distribution of malignancies as well as chemotherapy combination, what they have received. And what they have found is a highly emetogenic chemotherapy were it has reduced to 90% and moderately emetogenic 10%. So it was a study which has shown a current retrospective data and real world evidences which support the effectiveness of DEXA sparing enzymatic with NEPA for prevention of CINV in cancer patients. Another study by Soumya Sindari, that is, they have done generic netopatent and palanositron and DEXA for prophylaxis of CINV in high and moderately emetogenic cancer patients. What they have found, it demonstrate a promising efficacy of Nicron in combination with DEXA in preventing CINV in real world patients. And then the single dose DEXA plus NEPA for CINV prophylaxis in multi-day highly emetogenic chemotherapy regimen for lymphoma patients. So here, again, the result shows that DEXA sparing NEPA regimen shows remarkable efficacy in CINV, managing high and moderate emetogenic chemotherapy regimens, showing 100% response rate in both acute and delayed MSS control. So in summary of these studies and about the NEPA that or Nicron, the single dose combination of netopatent plus palansitron NEPA, that is called Nicron, demonstrated better efficacy compared with 3-day aprepitant-based regimen, according to result of a pooled analysis of multiple phase 2-3 studies investigating the prevention of CINV in patients receiving highly emetogenic cancer patients, chemotherapy patients. NEPA was also more effective than 3-day APR in preventing significant nausea, which is most difficult to control symptoms cisplatin-based high emetogenic chemotherapy and overall phase following chemotherapy 0 to 120 hours. NEPA, it has a rates decrease each day with significant lower rates of breakthrough CINV. This is related to longer half-life of netopatent, that is almost 94 hours, compared to aprepitant, that is up to 40 hours. So generic NEPA, Nicron combi pack offer good prophylaxis against CINV. So I think so generic NEPA can be considered in clinical practice, having, for the betterment of patient going for control of chemotherapy-induced nausea, vomiting. So this was from my side. Thank you so much for patience listening.
Thank you, Dr. HP, for one of the most important, having a word on one of the most important topic, which is MSS. We all have gone through a hell lot of exercises to correct the vomiting parts.
Yes.
So, in view of time, may I request Dr. Sonak, if it's feasible, to have some comments on relapse refractory ovarian cancer, his personal some comments over it, or maybe Dr. SP or Dr. Shyam Agrawal can follow.
Yes, sir. Good evening, sir.
Good evening.
So, personal comments. I have a couple of consecutive patients like this. Like during the last 2 years, we know that the accessibility to PARP inhibitors have increased. So, definitely in 2-3 years back, those that were required to take PARP inhibitors could not take it due to the cost of the drugs. And now we have data that says that we should be using PARP inhibitors in first line, and the efficacy in in a relapsed ovarian setting is less. But considering that the accessibility to PARP inhibitors have increased, I am still using the generic olaparib in relapsed platin sensitive ovarian cancer, and I don't see the point in trying to in trying to not make them use the drug, even though they are because they are still platin sensitive as well as germline BRCA mutated.
Very rightly said, Dr. Sonak. And sometimes when the patient is HRD negative, there is low volume disease, you feel it should be offered something. So at that times, do you offer hormone therapy? Maybe it may work or it may not work.
Sir, I have given tamoxifen as hormone therapy in the biochemical recurrence setting. But there is no advantage to that in terms of OS. I mean, eventually they do require chemotherapy, but we are kind of delaying the requirement of chemotherapy by a couple of months with treatments like tamoxifen.
Right. Maybe some quick comments from Dr. SP and then Dr. Shyam, sir.
I just have a sir sharing of my experience using PARP inhibitor in ovarian malignancies or in the breast cancer. So what I have compared or what I have seen that when I'm using generic PARP inhibitor as compared to the original one, I found the chance or percentage of anemia and myelosuppressions is higher in cases and blood transfusion requirement increase. So is it the similar kind of experiences you guys have when you are using generic versus the original one?
I think
Yes,
there
sir.
is a difference.
Agreed with you totally. And also, all those people on generic have had to reduce their doses to 150 mg BD within the initial 1 or 2 months itself.
Yes, 600 milligram, most of the patients.
Yes, 300 BD they're not tolerating. I mean, one patient out of say maybe 7, 8.
And almost every month or once in 2 months, we have to transfuse the blood also in these patients. So I don't know exactly what could be the change in the biology in these molecules when it is coming to the generic one. Well, let's see exactly. What is your experience, sir, Rakesh, about these using of generic or original one?
I was very comfortable with the original one, but with the newer ones, it's tough to say on.
Yeah.
So I see Dr. Akanksha is also popping up. So Dr. Akanksha, if you're comfortable. Hello.
Yes, sir. Yes, sir.
So can you suggest some of the key points you are using in your practice while managing relapse refractory ovarian?
Okay, sir. So uh, to begin with, the points, it basically depends on the platinum-free interval. I mean, you want me to cover those things or
Maybe
I'll just join? So,
it's just
yes,
brief. So because
yes, sir.
as the panel we are running
Yes,
late, so it's
yes, sir.
just we
Okay.
can just conclude
So, yeah,
with
those
few of the
points, yeah.
points.
Yes, sir. So the most important thing is platinum-free interval, and 6 months is the cutoff. So apart from that, how was the patient response to initial therapy and BRCA status? Whether what is the current stage? Was there upfront cytoreduction which was complete and current ascites? So if it's feasible to for the patient to undergo upfront and now present in relapse also, so if cytoreduction is possible or not. That is the first thing. And based on that, and obviously this platinum free interval, I take up the treatment decision.
Yes, you have very rightly
So,
said कि second line cytoreductive debulking surgery should there be in our minds while treating such patient. कि if
yes,
the
sir.
duration of response or the control of disease is longer, you can always consider for second cytoreductive surgery. Anything else you would like to add, Dr. Akanksha?
So apart from that, the agents that can be used. So if it's platinum sensitive, obviously paclitaxel along with carboplatin, and sometimes even PLD can also be used in place of paclitaxel. If it's platinum resistant, then other drugs can be used. Gemcitabine, PLD, etoposide, or even if we go towards metronomic, when the patient condition is poor, then metronomic chemotherapy with cyclophosphamide or etoposide.
Right. So these are the things which should be kept in our mind before giving up. We don't have much of the options up after third or fourth line. We can always try with endoxan, etoposide, our age-old molecules.
Yes, sir.
So, thank you, Dr. Akanksha, Dr. Sonik, Dr. SP sir, Dr. Sham sir, entire team for being a part of Oncology Conclave 2024 with a good mental feast for all of us, I feel. And I'm once again thankful to the entire team, all the pharma companies, Tarun Bhai and his team, which was there always with us. Thank you all.
Thank you, sir.
Back to
Thank you,
Dr.
sir.
Tarun Bhai.
Thank you, sir.
Thank you so much, sir, for giving this opportunity. With this, we close, and on behalf of my colleagues Abhimanyu and Summer, good night. Stay safe, stay well, and a very nice weekend. Good night, everyone. Thank you so much.